My name is Geoff Cundiff. I'm a pelvic floor reconstructive surgeon, which means that I trained as an obstetrician gynecologist, and then I did two additional training stints or fellowships to learn to take care of pelvic floor problems of the bladder and the rectum and vagina. Okay, so this evening we're here to talk about urinary incontinence and pelvic organ prolapse, which are really pelvic floor disorders. So we're talking about problems that occur with the pelvic floor organs, and that includes the bladder and the uterus, the rectum, and those disorders really include urinary dysfunction, and that can be either urinary incontinence, the loss of urine when you don't want to, as well as difficulty emptying your bladder, and that includes having to go too often and having to rush to the bathroom. There's also vaginal dysfunction, and so that refers to problems with support of the vagina and the pelvic organs that can result in a herniation or a bulging out through the vagina. And that can cause problems with sexual function as well. And then lastly, defecatory dysfunction really refers to problems with the bowels and with the rectum and anus. And that includes loss of stool when you don't want to, as well as difficulty evacuating. These are actually problems that aren't discussed very often, and so most people don't recognize how common they really are. In fact, if you look at women overall, the overall prevalence is 24%. So one way to think about that is if you look at all of the women in this slide, and now if you look at these women again, and notice the ones with an umbrella. These are the ones who have pelvic floor disorder. And so if you look at it in that context, it's actually quite common. Pelvic floor disorders affect both men and women, but they affect women much more commonly, twice as commonly, and they tend to occur earlier in life. So for example, loss of stool or fecal incontinence is twice as common in women, as is urinary incontinence. Yeah, so prolapse, I like to think of prolapse as a type of a hernia. And so what's a hernia? Well, we have these connective tissue layers in our body that hold in the soft tissue. And if you get a hole in one of those, then the soft tissue can bulge through, just like this buttonhole. And so those connective tissue layers include the abdominal wall, and you can get a hernia in your inguinal area, for example, but they also include the vagina. And so the vagina has a connective tissue layer in the front and in the back, and it also has support at the top. And if you lose that support, then either the bladder can bulge into the front, or the rectum can bulge into the back, or the uterus can actually bulge down and come out of the vagina. These support compromises are actually very common in women who've had children. Most women who've had children don't have perfect support, but it doesn't usually become symptomatic until it comes past the opening. And what kind of symptoms can it cause? Well, the most common are a sense of pelvic pressure or heaviness, sometimes a sense that you're sitting on something. Actually seeing it bulge out is also common. It can make it difficult, for example, to hold a tampon in. It can also affect your bladder and bowel function. So urinary symptoms might include having to go to the bathroom all the time, or having to rush to the bathroom, or leaking urine. And for the bowel, it can cause either loss of stool or difficulty of emptying bowels. Well, treatments for prolapse basically fall into three categories. And the first category is no treatment at all, because prolapse is it's not a life-threatening problem. It affects the quality of life. So if there's no symptoms, then there's nothing to be treated. And if the symptoms are there but they're not really that bothersome, then again, no treatment might be the most appropriate approach. But if it is bothersome, then the most common non-surgical treatment is a pessary. And a pessary is a device that fits in the vagina and holds it up. It's not unlike a diaphragm that you would use for contraception. And like a diaphragm, it's made out of silicone. And we usually teach patients to put them in themselves. Most patients can master that and take it out. And when it's in, you shouldn't even feel that it's there. But it holds things up and it relieves the symptoms. Not everybody can get relief from a pessary, or some people can't actually keep them in. So they're not appropriate for everybody. And for those people who can't use pessaries, there is the option of surgically repairing prolapse. And there's different approaches depending on where the problem is, whether it's in the front wall or at the top or in the back wall. Some of the approaches are done through the vagina, which is the easiest approach in terms of recovery. But sometimes we actually have to go through the abdominal wall to fix prolapse. I like to think of surgery as a risk-benefit proposition. So the equation of risk and benefits have to be favorable. And of course, the benefit is the relief of symptoms. So how bothersome it is really the most important in determining how much relief you're going to get. The risk, first of all, it's important to recognize that prolapse surgery is repairing something. And so it's not 100% effective. There are some people who it fails again. And other risks are surgical risks. So having to be off work, having to recover, risk of bleeding that could require transfusion, pretty rare, and other complications that, while rare, really need to be factored into that equation. When you're looking to have surgery, there's a lot of different surgical approaches. I would recommend trying to find somebody who does this type of surgery as their primary work, because some of the surgeries are not as effective for certain patients. And so having somebody who can really choose the correct surgery for you is important.